All right, we're going to get started, everybody. Thank you so much for attending this booth talk, which we've titled Keratoconus Management from Stabilization to Surgical Innervation, which was a catchy title by my student Karan here, who helped me put together this presentation. So we'll dive right into it. We've kind of changed the paradigm for how we have our decision tree for what we're going to do for our keratoconus patients. In the past, we pretty much said cross-linking, and after you cross-link, you watch, and then if they need a transplant, you do a transplant. Now our decision tree is a little different. If we have a patient who comes in and is looking for visual rehabilitation, we're talking first about CTAK, and then considering cross-linking after. If we're talking about the cornea is unstable and there are younger patients, then we start talking about cross-linking first, and then move on to CTAK after. So there's a little bit of a decision tree in how we consider our keratoconus patients. So this is how our paradigm works. It may not be the same for every practice, but this has been successful for us in how we envision patients or how we decide which pathway we're going to go to first. Because you can go either way with CTAK. You can do CTAK first, or you can do cross-linking first and do the other procedure after. So with cross-linking, our goal, again, as everyone knows here, is to stabilize and observe the cornea. So we perform cross-linking to halt any type of progression. CTAK can be performed after cross-linking. If CTAK is performed first, we usually want to wait about 3 months. But the sequencing or how we decide on the order of things is patient-specific and it's flexible. You can do that pretty much at any time. I want to dive right in now to CTAK. So what is CTAK? CTAK is a precise stromal pocket used using a femtosecond laser. CorneaGen will design a customized tissue for your patient. That tissue is gamma irradiated and it's implanted and helps to reshape the cornea. We're going to show some videos of this. And we've seen in our patient population improved uncorrected, improved corrected visual acuity. We enhance vision potential, and hopefully we're going to stop doing corneal transplants, full thickness corneal transplants for keratoconus patients. Obviously that's the goal for all of us as we're working with patients. What is the candidacy for this procedure? I know Dr. Greenstein yesterday spoke a little bit about inclusion, exclusion criteria. I'm going to give some of my input on that. So if you have someone with central scarring, they could be a candidate, but if it's going to get in the way of your channels, it could disqualify a patient for CTAK. And I definitely have some examples of patients who we attempted CTAK and weren't able to do because of some scarring or deep blood vessels or interstitial keratitis. If you have severe ectasia with poor structural stability, they may not be suitable, but honestly, I've been surprised with some of the patients that can actually have CTAK. Amazingly difficult corneas, and they actually do very, very well with that. You want to have a corneal topography, and if they have prior LASIK, you just want to be careful to learn where their LASIK flap is so that you can make sure that you're underneath that flap when you're actually creating your pockets. And I'll show an example when that didn't happen, so you can kind of just see what happened there and how we had to rethink things. When you're considering planning, you want to look at the manifest refraction. So this is, when we first started doing CTAK, we did it at the slit lamp. So we'd have the instrument, so this is me at the slit lamp putting the marks on the patient. And this was a great patient who didn't even need a speculum, and we were marking at the slit lamp. Now we mark under the laser, but at this time we were marking at the slit lamp. But you want to have refractive planning. So you're going to get some hyperopic shift with your patients. So if you have a patient who's starting hyperopic, you want to think through what they're going to end up and how you're going to deal with that. So they may not end up a lot more different, but you will see a refractive shift. So if you have your high myo patient, which is your typical keratoconic, you're going to probably be okay, but there is a level of shifting in their refraction afterwards, so you want to be cognizant of that. This is an example here of, we have a Zemer laser, which is very nice because it creates the actual tissue pockets in the exact angle and the amount of space or the length of the tissue. So you can see here it's creating the pocket for us, and then after the pocket is created, you have that nice, exactly where you want to place it, about 15 degrees more than the actual segment. And then our tissue insertion, just for those who haven't seen CTAK before, we basically use a Sinski, we open the pockets, and again, with the modern lasers that we have now, these channels typically are very smooth, very easily opened. We have the instruments specific for CTAK, and you can see the pockets being opened. Once you dissect those channels, We insert the tissue, and then we use the instrument to basically guide the tissue into the pocket. The thicker the tissue, typically the easier it is. The thinner tissue, if you're down to 200 microns, that's when you have a little bit of a challenge. You have to kind of work with the tissue a bit to get the tissue in position. But this is a 3-4 minute procedure in general, placing the tissue and having it in a segment. You put a little bandage contact lens and you're done. And the results are stunning. So you have a patient here with a change in their astigmatism, improvement of a Kmax from about 6 diopters, reduced astigmatism, and then the factor that I didn't know would happen is this uncorrected visual acuity improvement. When you have a patient with keratoconus who's functional, uncorrected, game changer. You have a patient it's a different ballgame. So speaking of data, so this is our first 50 patients. Okay, our first 50 patients, you have uncorrected visual acuity improvements, and we separated this by how steep their cornea was. So if the cornea was 50 diopters to 60, 60 to 70, 70 to 80, you can see the uncorrected visual acuity improves. Now, it's not linear, of course, because you have these steeper corneas. It's harder, of course, to get those patients to see better, but you do get improvements in all the categories. And then you talk about the flattening. This one is linear, and you see we even go up to 80 diopters, 85 diopter corneas, and we're seeing vast improvements in their cornea, in their corneal steepening. From a visual standpoint, functionality, you have pre versus post, and you can see here, I think the glaring point is you're getting improvements in most patients. It's rare to have a patient who doesn't improve some. You may not get as drastic as you hoped in some patients, but in general, you're getting improvement, and sometimes it's dramatically improved. And a number of our patients are excited after they have their CTAK procedure. So you can see here that we're even getting up to 80 diopters, and you're seeing large improvements in their visual acuity, uncorrected and corrected. So when we talk about the flattening, okay, you go from the small, of course, you're gonna get less flattening in the less steep corneas. When you get to the very steep corneas, you're getting up to like 11 diopters of flattening with these CTAK procedures. So it's sometimes very dramatic, and I would argue that this is something that any cornea practice should be offering to their patients as an option.